So I'm going to talk today about something that I saw many years ago and I've been trying to figure out ever since, and that is how you acquire a Chiari malformation after shunting an arachnoid cyst. And we're going to tell this. Have you ever heard this expression that a fact is more memorable if you put it in a story? I'm not sure actually if Jerome Bruner said this, but anyway, the story goes that he did. So once upon a time, there was a little baby boy who was born, and he suffered a skull fracture and during his delivery. And so they did a CT to look at the fracture, and they found an incidental arachnoid cyst and followed it up with an MRI. And the cyst grew, and this child came to me, and I didn't know what to do with it. And this was a long time ago, and I decided to put a shunt in it. Okay, so at 6 months of age, this kid here with a suprasellar arachnoid cyst received a cystoperitoneal shunt. Okay, that was in 1994, a long time ago. And at that time, I thought that you should get rid of arachnoid cysts, that the goal was to re-expand the brain, okay, to restore the contour of the brain. And I thought that would be the best thing for a person with an arachnoid cyst. So we did that. That was again in April 1994. And postoperatively, this is what happened. So postoperatively, the cyst collapsed and his tonsils herniated, cerebellar tonsils herniated. He was asymptomatic at that time. And I want you to look at the changes we have from pre to post-op. Okay, first of all, the cyst is gone. Second, and look at the cerebellum. Look at the loss of the CSF over the fovea, the expansion of the cerebellum, and the way it herniates out the foramen magnum. The pons becomes a little flattened. The corpus callosum thickens up, and the interhemispheric fissure is much less CSF in the interhemispheric fissure. The third ventricle is collapsed. The aqueduct is almost collapsed. So there's all these changes having to do with the overdrainage that occur after a cystoperitoneal shunt. So in that same year, that had never been reported before. And in 1994 was somebody in Saudi Arabia published an almost identical case, except in a 28-year-old. And they postulated that the problem was a differential pressure between the two compartments. Now that we'll see that doesn't make sense. But we'll see that in a little bit. So over the years, we started to see this. Okay, so we started to see multiple cases. Just look at the differences pre and post-op between these scans. And we started to see multiple kids who had this problem. So it seems like it's a thing. And there were further reports in the literature totaling about 12 patients, different ages and whatnot. So we decided to look at all of our patients who had arachnoid cysts and cystoperitoneal shunts, okay? And I wanted to find out what is the incidence of cerebellar tonsil herniation after a cystoperitoneal shunt, and I wanted to see what are the variables that have to do with it. So we found 65 kids who had intracranial shunts for arachnoid cysts. And I limited it to middle fossa or suprasellar cysts because they're the most stereotypical. Middle fossa is the most common, suprasellar is the second most common, and they're usually pretty stereotypical in their presentation. All the other cysts, like interhemispheric cysts and whatnot, are a little too variable, associated with other brain malformations and whatnot. So of this 65 that we pulled up, 13 had subdural shunts, okay? And these were kids who had either a ruptured cyst or a post-op hygroma, and 52 had the catheter placed within the cyst. Okay, so there's a difference in these types of shunts. We assume that the subdural shunt is going to work temporarily. The subdural space is going to collapse, and it's not going to work anymore. And then we usually take them out. So none of the patients with subdural shunts developed any tonsil herniation. So let's exclude those. So let's just talk about the kids with cystoperitoneal shunts. So as with arachnoid cysts, there's a male predominance. Most of them were in the middle fossa. Some of them had ruptured Some of them had undergone operative fenestration, and that's why, they developed a big subdural collection, and so they got a shunt. Average age was 4.6 years, and 6 of them had their shunts placed elsewhere. And it actually turns out that those are the most troublesome ones, are the ones who had their shunts placed elsewhere. 30%, 15 kids developed hindbrain herniation after their shunt, and this was defined as greater than 5 millimeters below McRae's line. So of those 4, it was thought serious enough to undergo Chiari decompression. Okay, so, and here's 3 of those kids. One of them was my index case. And you can see the last one had many operations for either the shunts, maintaining shunt patency, or operating on the Chiari, or operating on the syrinx, or whatever. So this is a problem. When this happens, these kids end up having multiple operations to maintain shunt patency and for their Chiaris. What were the variables? This is all patients who had cystoperitoneal shunts. These are the ones who did not develop tonsil herniation. These are the ones who developed tonsil herniation. And these are the most severe tonsil herniation who received operations. So there is a trend toward, a pretty clear trend toward younger age at the time of shunt placement, okay? A trend towards a bigger cyst, okay? And a trend towards a larger percentage decrease in the volume. In other words, the cystoperitoneal shunt was more effective in obliterating the cyst in the ones who had the most severe Chiaris. And then we looked at what the valve pressures were. There also was a trend if you put a higher pressure valve in to not herniate your tonsils. And with the low pressure valve, it was more likely. It was very hard to tell with the programmable valves because you didn't know what they were set at the time they had their scans, and you were trying to correlate the scans to the settings. So that was a little difficult to tell. But I think this is a real trend. So what is the role of CSF diversion in the development of tonsil herniation or a Chiari malformation? Well, we already know that if you put a lumboperitoneal shunt in, you're very likely to herniate your tonsils, okay? So most of the time, you will, if you look for it, you're gonna find that they've herniated. You can, some people believe you can mitigate this with a HV valve or whatnot, but lumboperitoneal shunts are notorious for this happening. Now, this makes sense, though. It kind of makes sense, doesn't it? You're shunting sort of a downriver fluid collection. You've got the pressure being generated from your brain. So you think of this as a cranial spinal pressure gradient, right? That fits for us. We think about that. Some people have postulated, however, that once you put a shunt in, then you end up, the skull doesn't grow, and then the brain wants to grow later, and then you have this cephalocranial disproportion, okay? I'm not buying it necessarily, but that's out there in the literature. And it can be serious, and people have, one of the patients in this series died after a lumboperitoneal shunt from brainstem compression. And so, all right, so this is a young woman who had very small ventricles and a difficulty maintaining a ventricular peritoneal shunt, and she had a lumboperitoneal shunt. And again, you see the lack of CSF. The cisterna magna has gone away. The chiasm is collapsed. All the folia are less. The CSF is gone from the folia of the cerebellum. And additionally, so the CSF also has a role with the ventricular shunt. So occasionally we see an acquired Chiari after a ventricular shunt. It's pretty rare. We don't know the incidence. And it's usually in kids with complex craniosynostosis, kids with Crouzons, Pfeiffers, less likely APERTs. If you put a shunt in a kid with venous outflow obstruction, especially little kids with vena Galen malformations, they will develop a Chiari. So there's something else going on there that we are not quite sure about. So if you look at, there's two patients with Pfeiffer's. This one never had a hydrocephalus or a shunt, and you can see that there's a little bit of a Chiari there. But look at this one. This is just amazing. Look at the change in the cerebellum after the shunt was put in. I mean, that's interesting. So when the other publications have looked at the pathogenesis, most people think that after you put a shunt in, there's some thickening of the calvarium, and then the space, the posterior fossa is smaller, and then the cerebellum just kind of herniates out because of a small cerebellum. The group from Argentina I think it's a little closer to the truth when they say that there's increased hydration, and I think it's more cerebral blood volume. But anyway, we haven't proven that yet. So here's some things that were interesting that I think help us understand the pathophysiology. So 3 of the patients with cystoperitoneal shunts had shunt failure. Okay, and during the episode of shunt failure, their tonsils reduced. So this is our index case, okay? And this, at 4 years of age, remember the shunt was put in at 6 months. At 4 years, the kid came in with bilateral 6 nerve palsies and headaches. Okay, the shunt had disconnected, and we were able to tap the proximal portion of the shunt and got an ICP of 55. Okay, so this is really interesting in that if you look at this, which of these pictures looks like higher pressure? I'm going to say on the surface of it, the left one looks like higher pressure, doesn't it? Okay, but this is low pressure and this is high pressure. All right. So this is communicating hydrocephalus in this situation. So what we see is the cyst with shunt failure did not re-expand. Okay, and that's quite common in these. So and the ventricles don't get bigger. So this kid is now shunt dependent in a way that mimics pseudotumor with relatively small ventricles. Okay, so that's another complication of cystoperitoneal shunting, is when we render these kids shunt dependent, and then their shunts become difficult to maintain because their ventricles are small and their cysts collapse. But the cool thing is the cyst doesn't re-expand, okay, if you put these in early enough. But look, the tonsils actually kind of reduce. Okay, there's still so the viscoelastic change in the tonsil remains. I don't know if it would round out if we left it enough time, but look, the cisterna magna is restored, and it actually looks better than this. But this kid's got bilateral 6 and a pressure of 55. So, anyway. So Dr. Wepperin observed this and said, okay, I can help this kid with his problem. So this kid had a middle fossa arachnoid cyst and a normal posterior fossa, in my opinion. And after his shunt, again, look at the difference. Look at how, I mean, there's no CSF here, right? And the tonsils are herniated. So Dr. Wepperin decided, well, I've watched, Dale's problems, and I'm going to be smarter. And he ended up putting in an Orvis Sigma valve, which nicely restored the CSF to the brain and reduced the tonsils. So the problem is probably not a small posterior fossa. Okay, the problem is it can't be a craniospinal pressure differential, right? Because there's not there. So the problem is probably that we're just taking all the CSF away, and you end up with you got 3 things in your brain, in your skull, right? And you're not making more brain, so it's probably just cerebral venous volume in there that's causing the problem. All right, so this occurs relatively frequently after shunting. It occurs in the younger kids, and the more you decompress the cyst, the worse it is, and it can be reversible. So I believe it's very similar to what happens when you put a lumbar shunt in, but we don't have this craniospinal pressure differential. And I believe it's from cerebral blood volume, and probably happens more likely in kids than in adults. So I've been interested in the mechanisms of cerebellar tonsil herniation for a while. There are other contributors oftentimes to Chiari's. We're finding, you guys are probably raised to believe that Chiari's are mostly acquired. When I was in training, everybody thought they were congenital. So we're seeing lots of acquired Chiari malformation. Does all this matter? Is this just an interesting observation? I think you can change. I think you can use this to help your practice pattern. For instance, this kid was a 3.5-year-old who came in with headaches and neck pain, had a middle fossa arachnoid cyst. Okay, and so actually he already had a Chiari. So I would think that this kid would really be, if we shunted this cyst, this kid would really be prone to worsening Chiari. So we, of course, and this is a dynamic picture, but we fenestrated it, and the cyst got smaller, but it didn't go completely away. Okay, this is acceptable, and his Chiari reduced. Okay, and we can see that sometimes when we do an ETV in a child with Chiari. Oftentimes the Chiari will reduce after an ETV. There's other applications. Once you start to think this way and you start to look at the pictures, and so you start to look at the posterior fossa in a little different way. So this patient came into me and she was scheduled. She had occipital headaches. It sounded like Chiari headaches, worse when she coughed and sneezed and everything. And she was scheduled for a Chiari decompression. And I don't know why she came to me. She was married. She was an adult. But if you look at this picture, is this look like a typical Chiari? No, it looks like all those ones that were overdrained, right? I mean, look, the pons is flat. There's no suprasellar cistern. There's no folia. The corpus callosum is thick, right? So I said, this looks funny. It doesn't look, normally, if Chiari's down here, your aqueduct's going to be a little bit splayed, even, right? Right. So this looked like a picture of overdrainage. So sure enough, the history was, if she laid down, she felt better. Okay. So what does she have? Yeah, she has a spontaneous CSF leak, right? And all she needed was a blood patch to get better. So when you start to see this picture of CSF overdrainage, you can kind of recognize a few of these things. And then finally, this kid was referred for syringomyelia, and he is one of those kids who had a lot of operations. He had 19 operations at 3 different institutions, and so he comes in for syringomyelia. And I get a little bit of history, and it turns out that when he was a baby, he had a cyst, a middle fossa arachnoid cyst. Initially had a normal posterior fossa, and after he got a cystoperitoneal shunt, then he developed a Chiari, and then he had developed a syrinx. And after multiple operations, the syrinx was still there. And why is that? Okay, well, people are trying to. Okay, they're decompressing the Chiari, all right, but there's still not enough fluid here, so the cerebellum sags, and their decompression doesn't work. So what we did was we converted his cystoperitoneal shunt to a high resistance ventricular shunt, and then redid his Chiari, and it ended up working. So sometimes we have to change the valve pressure to have a more, or get the shunt out to have a more successful Chiari operation. So at any rate, that is the end. So I'm also interested in these other aspects of Chiari's and how they influence your treatment modalities. All right, any questions? You'll see this. You will definitely, you will see this in your lifetime. It will come up, especially if you look back far enough in the history of people. I'm sorry?
Yeah, that was really interesting. I remember in training, we always pull the kids with Chiari's and hydrocephalus or who are shunted. It's the shunt dummy. Like, check the shunt first before you do anything else. And this is almost the
This is
opposite,
backwards.
right?
This is backwards. Yeah, exactly. Yeah, you have to
So
get rid of.
what's the difference between, you know, a hydrocephalic who gets high, and I guess this is exactly what your point is. How do you reconcile, you know, hydrocephalics who are undershunted will have hindbrain herniation, and this is like with cysts, if they're overshunted, they get hindbrain herniation. I guess the mechanisms can be completely distinct.
Yeah, the mechanisms are very different, and so a Chiari-2 is going to be different, and but the origin of a Chiari-2 is still probably CSF loss. It's just in utero, but yeah, there's a balancing act to make sure that you don't have high intracranial pressure that's making your Chiari worse. So yeah, there's a little bit of a balancing act there and a bit of judgment. Yeah.
Dr. Swift, I have a question.
Hey.
Hey, good morning.
Sounds like Brett. Yes.
Yeah. Why do you think that the biggest changes in the brain volume and engorgement happen in the posterior fossa, even if you're cysting a supratentorial cyst?
That's a good question. I don't know exactly. I think that first of all, cerebellar growth in infancy exceeds the cerebral growth. Okay, so the cerebellum grows faster, and so there may be some change in how fast the cerebellum goes, and you have less. I think you have less room to move there when you know the supratentorial space is also engorged, but it's just not. You don't see the effect of it. But I don't know why exactly. I don't know why it's particularly in the posterior fossa. You know, I've never seen like an uncle herniation or anything like that. So I think it has to do mostly with the cerebellar growth early in life, and also the cerebellar tonsils are a little bit lower early in life than later in life, and the velocity of the CSF at the foramen magnum is higher. So it could be that you end up with a dynamic situation where with pulsations, the cerebellar tonsils just get swept into the foramen magnum and impact, and then that's it, and they mold that to that position. So.
Yeah, I have one more question. So you started this with saying, you know, when you early in your practice, you thought when there's an arachnoid cyst, you need to get rid of it. You need to re-expand the brain.
Yeah.
But now that you have this experience and, you know, the rest of your experience, and I'm sure you covered this on the pediatrics rotation, but what is your approach or thought process when you see arachnoid cysts in terms of their management now?
First of all, not all arachnoid cysts need to be treated. We can find you're gonna see a lot of arachnoid cysts, and you don't have to do much for most of them, for small ones, and they're not going to get bigger after about 2 years of age. So if you see an incidental arachnoid cyst in a kid with head trauma or something, or an adult, you don't need to. It's not going to change. What might change is they might rupture into the subdural space. Okay, then that can be a problem. I'm very aggressive about fenestrating them. And we have known complications with fenestration that we have to deal with because they oftentimes develop intractable subdural fluid collections after fenestration. So you just have to be ready to deal with those and have a philosophy to deal with those. That's. But yeah, so I don't like to. I'm really cautious about shunting them. If you end up with somebody with a shunt, then I really want either a programmable or a Orbisigma, a high resistance valve. I think those will help if you have to shunt them. When I went back and I reviewed all these patients, it was very clear that they had chronic headaches. Many of them were coming back in multiple times. They weren't necessarily having surgery, but they had headaches, and they would have ICP monitoring, and their pressure would be low, and everybody said your shunt's working, but they're probably having, you know, low pressure headaches and over drainage. So. But you can see that one case with the syringomyelia, that started out as an arachnoid cyst, okay? And it comes back as syringomyelia. I mean, that's just a interesting connection. Well, thank you all.